So I'm going to start with the mostly discussed topics of these days that are COVID-19, disease and support of immunity. This was also one of the most frequently asked questions by our attendees. Now, you have recently published a review article focused on immune parameter changes in patients positive for COVID-19. You also take care of patients hospitalized in your hospital with severe or critical course. So what do you think? What is the role of immune system in respect to either prevention or fighting COVID-19?
Okay, so this question was quite expectable because everybody is asking also in our country about the possibilities and all about the role of immune system in COVID-19. What is very good is that during the last like 8 to 9 months, we finally are quite more familiar about the changes of immune system during the COVID-19. The first thing what is very important is that COVID-19 is currently considered to have 3 phases, not in each patient, but basically we can distinguish between 3 phases. The first one is like classical initial viral phase, which is associated with increased body temperature, with cough, with some systemic symptoms of respiratory infectious like muscle weakness, fatigue, flu-like syndromes, and so on. And very typical finding during this first stage is the leukopenia and lymphopenia, so decreased absolute counts of lymphocytes. This is quite interesting because basically in general in viral infections we expect the increased numbers of lymphocytes and leukocytes. So in COVID-19 this is a little bit different and we can find that the numbers of lymphocytes are decreased. Then certain patients are able to go to the convalescence and do not have any consequences of this phase, but some small proportion, especially of the risky patients, are switching to the second phase, which is connected with ongoing inflammation in the lungs, in the lung tissue. The patient usually starts to feel dyspnea, starts to have very severe cough, requires oxygen therapy. And during this phase, you can see the clinical changes on the X-ray or computed tomography. Usually the findings is like bilateral bronchopneumonia or ground glass opacities, which are typical for interstitial pneumonitis. Then in small proportion of the patient, it comes to the third stage, which is very severe because then you see the development of multi-organ failure system. The patients require artificial lung ventilation. Then during this phase, it's very interesting that the previously quite non-active immune system is starting to be overactive. And a very popular term is cytokine storm. So you can see the rapid increase of interleukin-6, of CRP, of procalcitonin, which is accompanied by increased ferritin and some other inflammatory markers. And during this phase, it comes to the severe inflammatory damage of all the body organs like heart, liver, skin, or especially lungs. And unfortunately, some of these patients which are coming to this stage unfortunately die because there is uncontrolled hyperinflammation which without any sufficient control. Based on these 3 stages, there is also 3 types of immune response. In the first one, we can suppose that there is some inactivity of immune system. So we suggest that during the first and even second stage, it's quite logical to support especially antiviral defense. Also based on our experiences, not only on this reviewer article, but also about the results from our patients cohort, which is now increasing, unfortunately, and we are trying to submit these results from this cohort. It seems that during the first 2 stages, the immune function is suppressed. Then you have the decreased numbers of the cells which are involved in the antiviral protection, like CD8 T cytotoxic cells, natural killer cells. Another very interesting finding during this stage is decreased expression of activation molecules, which is accompanied by increased expression of inhibitory molecules. So you have the lower counts of the cells which are inactive. Sometimes it's called like immune paralysis. So therefore, in the first two stages, also in our patients, we are just trying to support the immune system, to support the antiviral effects. Depending on the findings in immune system, we are either using in the first stage the combination of beta-glucans together with zinc, with high doses of vitamin C. Unfortunately, in certain patients, it comes to the third stage, which is the hyperinflammatory syndrome or cytokine storm. In this stage, is absolutely crucial to be very careful in modulating of immune system, and certain recommendations are to use for example, monoclonal antibodies against interleukin-1, interleukin-6, or some other immunosuppressant agents. But we should honestly say that up to now, despite 8 months of COVID-19 in worldwide, there is still insufficient amount of well-controlled, well-designed studies which can support the use of certain preparation medications, synthetic medicaments, but also, for example, some natural immunomodulators for particular patients with the COVID-19. So basically, to summarize this, during the first two stages, we are trying to support immune system functions. We are just trying to restore the immune paralysis. We are trying to support the functions of natural killer cells. In the last third stage, in the most severe forms of the patients, we are just trying to control and to suppress the immune reactions. So basically, also according to this and according to the findings in a particular immune profile in each patient, we are just trying to add complementary to the other medicaments, like which are used. Doesn't mean whether this is remdesivir or previously hydroxychloroquine or some other medicaments. We are just trying to add also the immune support with quite very good efficacy and also with very good safety profile, I should say.
Thank you very much for your detailed information. The question that arises is also linked to Imunoglukan P4H in context of COVID-19. So what do you think, could Imunoglukan P4H be considered a safe or potentially beneficial immune modulator also for some patients with these first two stages of the disease?
Honestly, we should say that up to now, we do not have any controlled, double-blind, placebo-controlled studies, not only with beta-glucans or biologically active polysaccharides, but also with the other natural immunomodulators. So we can only take into account the previously confirmed mode of actions in other respiratory infections or other diseases. For example, the support of natural killer cells, activity, increased number of natural killer cells, or some anti-inflammatory and anti-infectious mode of actions. And taking into account these facts, we can also use natural immunomodulators, for example, beta-glucans or imunoglucan, especially in the mild and moderate forms of COVID-19, when it's absolutely essential to support the immune functions and to restart the antiviral protection and antiviral immune reactions. Beta-glucans, besides their immunomodulatory activities, especially on the natural killer cells, CD8 cells, and so on, has also anti-inflammatory effects. In certain studies, beta-glucans were proven to decrease the production of tumor necrosis factor alpha, to decrease the production of interleukin-6, even to increase the natural inhibitor of interleukin-1 in the body. So there are also some mechanisms which are confirming that beta-glucans can act, besides immunomodulatory, also like anti-inflammatory. And the very another important thing is the antioxidant mode of actions, because we know that inflammation connected with COVID-19 is strongly connected also or associated with increased oxidative stress, which is damaging the biomolecules, proteins, polysaccharides, and so on.
Thank you so much, because this is very frequently asked questions nowadays. As our majority of our attendees are pediatricians and pharmacists, they have been asking also for some practical tips how could they distinguish COVID-19 from common cold or seasonal flu, especially in this risky infectious period? Are there maybe any symptoms that are typically reported by COVID-19 patients?
At first, we will speak about the discrimination between flu and COVID-19, because common cold is usually a mild disease which is strongly related only to the symptoms from upper airways, which are not so frequent in COVID-19. This is very important. But basically, when we compare the flu and COVID-19, the first important question is whether the patient is vaccinated against the flu. And taking into consideration the high efficacy of flu vaccination against the severe forms of flu, like it's approximately 85 to 95% of efficacy, then if the patient is not vaccinated, then really we should force the true discrimination between the flu and COVID-19. The first thing is that there are quite interesting differences between the symptoms expression between different ethnics. Like in Asia, some symptoms are dominating compared to the, for example, Caucasians in Europe. And the first thing is the fever. In flu, it's very typical that the prodromal stage is very short. It's like 1 to 2 days. And 1 to 2 days, so the patient starts to feel very ill very soon after the infectious. Compared to the COVID-19, when usually you have the prodromal symptoms for 5 to 7 days, even in certain patients, the prodromal stage is up to 10 to 14 days. So it means that unfortunately COVID-19 infected patients, or more precisely, we should speak about SARS-CoV-2 infected patients, can spread the virus into the population, into the society, also without any clinical symptoms before the onset of clinical symptoms. But basically, the fever is much more higher in flu, usually lasts for example, several days, like 3 to 5 days. In COVID-19, fever is very typical symptoms from Asia. Approximately 90 to 95% of patients has fever, but it's not so high compared to flu, and it's usually not so long compared to flu. In Europe, the fever is described approximately in 50 to 60% of the patients. So the fever is not essential part of clinical presentation in Europe. The second important thing is the muscle weakness, fatigue, which is very early onset symptom in flu. In COVID-19, it's slowly developing after several days after the onset of clinical symptoms. And then regarding the gastrointestinal symptoms, flu is, especially in children, typically connected with gastrointestinal symptoms like diarrhea or some nausea, or the children do not want to eat a lot. In COVID-19, also in certain patients, you can see the diarrhea, and even some patients can shed the virus via the stool. When we have a look on respiratory symptoms, very important screening marker in COVID-19 is the loss of smell. It's like 80 to 90% of the patients, like very sensitive screening marker. Then regarding the symptoms from lower airways, cough is very typical for COVID-19, and also dyspnea is much more typical for COVID-19 compared to the flu. Besides this, we have some also extra respiratory symptoms, for example, conjunctivitis, which can be seen in approximately 1/3 of the COVID-19 patients. So usually, if you see during this period the patients with fever, cough, dyspnea, with loss of smell, conjunctivitis, and patient with typical findings, for example, in white blood cell count with decreased number of eosinophils, is very, very sensitive for COVID-19. You can consider that these patients will be infected by SARS-CoV-2. Now, on the other hand, of course, you need very, very precise laboratory confirmation. The best one is the PCR test. Unfortunately, the classical serological testing in COVID-19 are not so very sensitive compared to the other infectious diseases.
Thank you very much for your detailed information, which will be very valuable for our attendees in their clinical practice. Another question has arisen with regards to COVID-19. Do you think that immunoglucan could be a possibly effective preventive tool against COVID-19?
Okay, so for the prevention, we up to now, we do not have any double-blind placebo-controlled studies with whatever preventive synthetic or natural immunomodulator. So therefore, it's very important to say that regarding the recommendation of the use of immunoglucan, but also some other natural immunomodulators for prevention of COVID-19, we should only extract the results from the other studies and taken into the account the mode of action of immunoglucan, the effects of natural killer cells, stimulation of CD8 cells, prevention of respiratory infections. It can be one of the possibility of complex prevention of COVID-19 and some other respiratory infections. I would recommend also alongside with this to use the vitamin C, to use the zinc, or to use some other natural immunomodulators like vitamin D, which is very essential immunomodulator as well. But we do not have any clinical result, any clinical trials with whatever immunomodulator, because up to now we have only 8 or 9 months of experience with COVID-19. So we will be waiting a little bit more. We will see for how long we will be in the contact with COVID-19.
Thank you so much. We have another question related to the mode of action of immunoglucan. We know that it's insoluble and non-digestible. Is there any chance that it could be absorbed by gut-associated lymphoid tissue?
This is very tricky question because up to now, certain mode of action of whatever biological active polysaccharides are theoretical, and some of them were proven also by clinical trials and animal studies. We know that the most proportion of these non-insoluble beta-glucans are absorbed only to the surface of Peyer's patches or to the gut, and then are processed by dendritic cells, by monocytes, and other immune cells which are placed in close connection with the mucosa. On the other hand, there is also the possibility that small proportion of, for example, immunoglucan, but also some other insoluble beta-glucans can be processed by, for example, phagocytes like neutrophils and macrophages, and after the phagocytosis into these cells, it can also stimulate their activity, and then they can be transferred to the other parts of the body. But the majority of these insoluble beta-glucans are placed only on the surface of Peyer's patches on the gut, and then they are interacting with dendritic cells and some immune cells. So some theoretical proposals were that some proportion of these insoluble glucans can be also processed by the phagocytes, but up to now I am not able to cannot say anything to us. But probably this is also one important part of the complex immunomodulatory activity of these products.
But as you mentioned in your presentation, the SPRITE study confirmed that immunoglucan has not been detected in the blood.
Yeah, exactly. So we can say that there is a publication that even in increased dosage in the peripheral blood of healthy volunteers, there was no detectable amount of immunoglucan after the perennial ingestions. So it also confirmed not only safety but the proposed mode of action that is working especially through the gut or gastrointestinal associated lymphoid tissue and Peyer's patches.
Thank you so much for that. We are coming to the end of our webinar, so I will ask you the last question, and that is the safety of immunoglucan for pregnant or breastfeeding women.
Well, up to now, we do not have sufficient data about the use of immunoglucan in a pregnant woman or in breastfeeding woman, but this is valid for all the other immunomodulators, that it can be used after a consultation with the treating physician, after the evaluation of the ratio between the risk and benefits. So in case that really the pregnant woman is suffering from very high rate of infections, which can have negative effects or impacts on the fetus, after the third trimester, after the consultation with treating physician, there is also this possibility, but we should honestly say that we do not have any sufficient amount of the data regarding the safety of this product in gravidity.
Thank you very much, dear Professor, for your precious time and sharing your tips, recommendations, and best practices with us. We are now approaching the end of our webinar, but before we finish, I'd like to thank you for joining us at this webinar. Ladies and gentlemen, we hope you have gained valuable information on the use of immunoglucan in your daily clinical practice. Please feel free to ask any additional questions or comments that might arise, ideally via our local partners in your country, but of course, we will address them and via partners. We hope we meet you again very soon and have a lovely rest of the day. Bye.
Thank you very much.